KRONOS is a study that was designed to look at the impact of a triple, which is a combination of a long-acting beta agonist, long-acting muscarinic antagonist, and inhaled steroid, all in one product that has being developed for coming to market. And so it was looking predominantly at lung function. We use these a lot with exacerbations for inhaled steroids, but this was mostly looking at lung function. And so as a result, it was looking at a population that is not a high-risk exacerbation population, what we would traditionally call Gold B patients, about 88% of them in fact. And so we showed with this that, not surprisingly, that if you add dual bronchodilators, they're better than a LAMA plus an ICS, and if you do a triple, that's better, and we looked at that. And so those were the primary endpoints to show the value of these added combinations against the duals and things like that. So that was really the important part and why the study was done. But we did secondaries looking at quality of life and exacerbations. And so even though this population was not at risk for exacerbations based on history, lung function, prior exacerbations, in fact, we saw a pretty amazing exacerbation signal where the triple therapy significantly reduced the number of exacerbations rate compared to the dual bronchodilator. The LABA ICS, which has the ICS, also it was a little bit better than that, but significantly it was the triple versus the LABA-LAMA, and that it was almost a 50% reduction in the number of exacerbations in these patient population. And that really causes us to scratch our heads. So we have this concept of who do we use an ICS on? Well, it's these high-risk exacerbation patients, and yet we saw a lung function signal and an exacerbation signal in this population. So you look at it and say, well, the reality was 70% of these patients were already on an ICS before coming into the study. And the first thing it told me was maybe the doctors knew what they were doing. And they actually had them on this triple therapy because they felt it was a benefit. And that even though it didn't meet the guidelines or the recommended criteria, that in fact these things do matter. And now we're going to have to take this back and ask questions about how do we define the right patient population? And in fact, are triples really a broader population than what we should originally have thought of in terms of who should be on these medications? One of the other secondary outcomes that we looked at was we actually looked at eosinophiles as a biomarker and did that predict, and we did see that clearly we got a better lung function signal and a better exacerbation signal in the subset of patients that had higher eosinophil counts in the KRONOS study. And so we're sorting all these things out. So I think that as this information comes in, the pendulum may swing back a little bit to where we are going to reopen up who should be on ICS and when, hopefully with some biomarkers or other things to do it, so it's just not everybody. But yeah, I do think it should change what we're going to do a year or two down the road.